Exam 2 Blueprint Think Tank. I hope you all are ready to write down your notes and get going. I will say that everyone did very well on the last exam, Exam 1. I was very impressed with the grades. And thank you, Viva. Good evening. Good evening, Dr. Lewis. I didn't see you on there. Does anyone have any questions? Good evening. Good evening, Dr. Griffin. Does anyone have any questions before we get started? I do want to say, I want to ask you all to please bear with us as I talked with Dr. Reiser and she wanted me to be sure and announce this. Please bear with us as we are grading your midterm videos and your SOAP notes. We're going to do our very best to get those turned around as quickly as we can. However, we have encountered lots of technical challenges with that, and but that's not you all's fault. So please just bear with us. We're going to work very hard to get those turned around as quickly as we can, but it won't be as soon as we kind of thought and had hoped for. So just bear with us with that. If no one has any questions, we're going to go ahead and get started. Cody, when do we find out about the peer review? Dr. Reiser's working on that. We can see where you all have submitted your peer review submissions, but she's working on that with the iDesign, iTech people to get that all sorted out, okay? So please don't worry. If there's anything wrong with your submission or anything, we'll let you know. We'll email you and let you know. For right now, you guys just keep working in the course and just keep moving forward, okay? Unless you hear different from us. Okay, y'all tell me what you know about the Weber test. What do we use the Weber test for? Okay, for hearing.
Yes, for hearing loss.
Hearing loss and for tone, very good. And how do we know if the Weber test is performed correctly? What's a normal finding?
Equal on both sides, and equal on both sides. And is it the 2 to 1?
Mm-hmm. That's
Okay.
The Webers if they hear it equally on in both ears, right? Okay.
Yes.
What's the Renee?
That's the 2 to 1.
That's
right.
The 2 to 1. Yes. Very good. Okay. All right. Let's say you have someone that comes in and you think that they have a foreign body in their nasal passages, in their nasal airway. Okay. What would be a symptom that would clue you to that pretty early on before you even examine them? You know, if they come in and they tell you, you know, hey, I got something stuck in my nose or whatever, what would be a symptom that would clue you to that's what's going on?
Would an odor be anything?
Mm-hmm.
Foul odor?
Yes. So all of those, very good, guys. I'm looking at your chats as they come in. So compromised patency, the foul odor. Okay, you may even see some drainage coming from that side, whether it's one side or the other. One nair, like you said, will not be patent. Correct. Okay, so one nair will be patent and one will not. But usually you can smell these folks before you see them. Okay, so they'll have a foul smelling odor. All right. What are the symptoms of tonsillitis? Tonsillitis, what are those symptoms?
Swollen, red, exudate.
What color is the exudate?
White.
White. Very good. Very good, guys. You're coming in strong in the chat. So white exudate. Okay, and erythema of the tonsils, okay? These patients are going to come in complaining primarily of what? What's their chief complaint? They'll tell you they have a what? Sore throat, okay? Sore throat. So they'll come in complaining of a sore throat, and what will key you to know that they have tonsillitis is that their tonsils will be erythematous and they will have white exudate. All right. When we talk about trench mouth or ulcerative gingivitis, what are the symptoms of that? What's the presentation for trench mouth? Okay, swollen gums. That's one. Okay, bleeding. Very good. An odor. Very good, Cody. They'll have foul breath. Okay, swollen, bleeding gums, bloody gums. It's an acute onset of painful, bloody gums, and they'll have a foul odor. Okay, so you got to remember that the key there is that it's kind of an acute onset of painful, bloody gums with a foul odor. What color is the exudate that covers their interdental papilla? Yellow white. Also, you're getting warm. Yellow white. It's more of a grayish color, okay? More of a grayish color. Grayish exudate, okay? And it's going to be covering the interdental papilla, right? So you have someone that comes in for tonsillitis or acute pharyngitis, all right? And you've seen them, you've examined them, you've noticed that they do have all of the positive symptoms, so fever, sore throat, pain that affects their swallowing, and you suspect that they have acute pharyngitis, all right? It's very important to rule out with that diagnosis, what do you need to rule out? Okay, they have exudate, very good. Strep throat, okay? It's important to rule out strep throat, right? So what diagnostic test do we use for that? A throat culture, very good. All right, so you want to be sure and do a throat culture or a rapid strep. Now we have, I know they use them a lot in the ERs, the rapid strep tests, okay? Which tests for the strep antigen. So you want to do a throat culture or swab or a rapid strep test. So you have someone that you suspect has, or they have symptoms of oral candida. What are those symptoms, first and foremost? White patches, white cheese-like patches, and where are they? Where are they located? The dorsum of the tongue, okay? So we know that we suspect that they come in and those are the symptoms that they have, so we suspect that that's their diagnosis, right? What diagnostic tool are we going to use to confirm that? Remember, what do we use? We learned this on in the previous modules material. What diagnostic tools do we use for fungus?
The scrape. The scrape, is it the gram stain smear?
Yes, very good. The scraping, okay? So gram stain smear and the culture of scrapings, okay? Very good, guys. Okay, you've got someone that comes into the ER, they are presenting and they've just been in an altercation, okay? You're examining them, they've had lots of facial involvement. And so you're examining them and you look in their nose, not their nose, their ear, and you notice that their tympanic membrane is a bluish color. What do you suspect? What does that mean? Blood, okay? They have blood, okay? Not necessarily perforation, but you definitely first need to know that there's blood somewhere. And most likely it's if it's in the tympanic membrane, if the tympanic membrane is blue, that's going to be in the middle ear, okay? All right, so what are some signs and symptoms of serous otitis media? amber or yellow color of the tympanic membrane. Okay, that's one. Very good. What else? Okay, and what color is the discharge from the ear? So we're talking about serous otitis media. What color? It's clear, usually like clear to sometimes maybe like a slight yellow tinge color. Okay. And what might the patient complain of that might clue you? They may come in and they may complain of that might clue you immediately to thinking that, oh, this might be serous otitis media. They may complain of hearing loss, but how will they say that it sounds? Crackling sounds, very good. Sounds like air bubbles, very good. Especially when they what? When they yawn, okay? So, very good, Danielle. When they yawn, they will complain of it feeling like a crackling noise in their ear, or they may hear air bubbles, okay? So know that about serous otitis media. Know what the discharge looks like, the presenting signs and symptoms, and mainly know that if someone comes in and they complain of like a crackling sound, air bubbles, muffled, or anything like that, then it's probably serous otitis media. What do y'all know about Ramsay-Hunt syndrome? Tell me about that. What is it caused by? Okay, it's caused by the herpes zoster and herpes zoster virus. Okay, in particular, herpes zoster oticus. Okay, all right, because again, it's located in the ear. All right, patients will have severe pain in one ear for several days before other symptoms will manifest. That is key to know. Okay. Because people will almost miss that diagnosis. I remember when I was back in clinic, I almost missed that. There was a patient that came in and she had been having pain for like several days, and it started very acute. It was like just the worst pain ever in her ear. And Ramsay-Hunt syndrome was not in my list of differentials. I didn't even think about that. And so in discussing it with my supervising physician, my collaborating physician, he was like, oh, he said, did you think about Ramsay-Hunt syndrome? And I was like, oh my gosh, I didn't. And so I called her that evening and had her come back in the next day. And sure enough, that was what she had. So the reason that it was not on my radar is because the main symptom will be an acute onset of pain, and they'll have it without any other symptoms for several days. Okay. So you guys be very aware of that. It's a very disabling diagnosis. It causes lots of other issues, and it's very, very painful. Okay, because you think about shingles anywhere else on our body, just getting shingles on our back or wherever, how painful that is. You can imagine in a small area like the ear. Okay, and this lady couldn't lay down on that ear. She could not do anything. She couldn't stand for the wind, she couldn't ride with her windows down. She could not have her phone up to her ear. It was very disabling for her. Okay, so again, an acute onset of pain that can last several days, and these people may have, when you initially see them, they will likely not have any other symptoms. So they may not have any ear discharge. They may not have any swelling or bulging tympanic membrane. Okay. And so that's why it can kind of be misleading, but that definitely needs to be in our differentials, okay? So an acute onset of pain lasting several days, and they may not have any other symptoms. Their exam may be completely normal, all right? Okay. All right, you have someone that comes in and they are, we call them like chronic sniffers, okay? They're chronically sniffing, messing with their nose, they're doing this, they get frequent nosebleeds, they have lots of discharge and coming from their nose. What do you suspect is their issue or that they abuse? Very good, guys, cocaine, all right? That's almost inevitable. I mean, it doesn't matter what people look like. if they come in displaying those symptoms, usually it's from chronic cocaine use. I know Dr. Griffin sees a lot of that with, yes, with cardiovascular disease, people who are who abuse cocaine. And it can lead to perforation of the nasal septum, all right, and chronic rhinitis. Which sinuses do we have readily available to us for physical examination? Which ones can we physically examine all the time? Which sinus cavities? The maxillary and the frontal, all right? You guys need to know that. Those are the ones that are accessible to us for physical examination, maxillary and frontal. When we talk about breath sounds, you should always be able to hear and auscultate breath sounds, right? Okay. So in what disease processes you might not be able to hear breath sounds, or they may be muffled? Okay, COPD is one, pneumonia. When we talk about them being completely absent, so if you don't hear any breath sounds when you auscultate, what might the patient have? Pneumothorax, y'all are getting warm. Think about what causes, what would cause you to not have to be absent of breath sounds in the respiratory system. Pleural effusion, okay? Because what is a pleural effusion, guys? It's a collection of fluid, all right? All right, fluid around the lung. So if someone has a pleural effusion, and if it's pretty significant, it's going to be very hard, almost impossible to hear breath sounds. I mean, you're going to be able to visually see that the people are breathing, so you know they're not in any distress, right? But when you go to auscultate their breath sound, if you are not able to hear anything, then it's a common indicator that they could have a pleural effusion, okay? So remember that. Breath sounds are typically absent in patients with pleural effusion. Dr. Lewis, Dr. Griffin, do y'all have anything so far?
No, just let me know if you need me to chime in. I'll try to help.
No, you chime in. If you have anything else to say or add, just chime in. I'm just running through here pretty quickly.
You're doing great.
Dr. Griffin, were you saying something? I'm sorry.
I was just saying you're doing so great. You're so quick that I can't even hardly keep up. Like I'm impressed with the students, how fast they're keeping up. Y'all are amazing. Y'all got some young lives.
Yeah, and young hands. They're y'all are being so attentive, and I love how y'all are in the chat. That is great. So a big thing for me, and I know I've told y'all this, is we like to see you being interactive, and y'all are doing really well with that. And for the most part, the things that I'm spitting out, y'all are on top of it, and you know. All right. So that's what we like to see with the think tanks. Okay. So symptoms that you would see in someone who has a foreign body aspiration, they've aspirated a foreign body. Okay. What is some objective data that we would be able to visualize? They're going to come in how? They may have stridor, high-pitched sounds, very good. Excessive salivating, drooling. Oh, Lord, I hope not. They are in distress. It's bad if they're drooling and salivating, but yes, foreign body. Dyspnea. How are their respirations? Thank you, Dr. Griffin. Tachypnic, they're very tachypnic, okay? So no, all of those things that you all said, they're very correct. Also, I would know tachypnic, okay? They don't have slow respirations. Their respiratory rate is increased, okay? So know that. If they have a foreign body aspiration, they're gonna have tachypnea, all right? So when we talk about characteristics of cough, Okay, lots of different coughs. You have wet coughs, dry coughs, and things of that nature. If you have an irregular, dry, and brassy cough, what would you suspect the patient has without any imaging or anything like that? What would you think if someone comes in and they tell you that they've had an irregular, dry, brass-like or brassy cough and they've had it for 4 weeks or 6 weeks? What's one of the first things that you would think of as far as your list of differentials? AFib, bronchitis, okay, maybe. Think a little worse than that, guys. So the key word here is brassy. This cough's not going away. It's dry, it's irregular, and it's brassy. A dry, irregular cough. Asthma, tumors, very good, all right, tumors. Okay, Dr. Griffin, do you know where is the characteristics of the cough associated with tumor? I have page 393, but that was in the old book. Let me look real quick. These are from my old notes. Or Dr. Lewis?
Is coughing is similar to the seals bark like a child with croup.
Mm-hmm. And I think someone put that in the chat. It sounds kind of like a croupy cough.
Yeah, Cody did.
Mm-hmm. Thank you, ma'am. So y'all be sure and know about that, okay? Dry, irregular, brassy type cough, you need to be thinking about someone having a tumor. And this is even before you image them. And the reason that will help guide how you interview the patient as well. Like, are you a smoker? Is there anyone in your family history with cancers, in particular lung cancer? If they come in and they tell you if they're able to tell you the characteristics of this cough, then that will help guide how you interview the patient as well to determine, if this could possibly be. Thank you, Dr. Lewis. Page 209, she said in Rhodes and Peterson, if this could be someone with a tumor. Go ahead, Dr. Griffin.
Yes, I was just going to say, Andrew asked in the chat, what does brassy mean? So brassy, like a brass instrument, like a trumpet or trombone, when you get that irregular, I'm not a good singer, or actually I played the trumpet, but I can't make that noise. But brassy in the sense that you feel like it's coming from a musical instrument. Does that help, Andrew?
You're welcome. And yeah, it's on page 209 under the quality of the cough. It says a dry cough may sound brassy if it is caused by compression of the respiratory tree, as by a tumor, or hoarse as if it's caused by croup. So very good. When we talk about Biot, so B-I-O-T, all right, Biot's breathing, what is that indicative of? It's an abnormal breathing pattern, right? And what are we concerned about if we see someone that, very good, Cody, neuro, that comes in with that abnormal breathing pattern? Okay, increased intracranial pressure, very good, everyone. And kind of, how does that breathing look? We kind of know what it is and what it comes from, but what is their breathing pattern like? Their respirations, are they regular or irregular? Irregular, okay. They have periods of apnea, very good. All right, very good. Y'all are on a roll here. Okay, when we're talking about, it varies, yes. Dr. Griffin, I thought you were one of the students. I'm sorry.
I am forever a student, forever.
Yeah, we're forever learning, right, Dr. Lewis? We feel like students. Okay, guys, when you're percussing, Okay, we talked about percussing, and we have gone through that on our checkoffs, doing the head to toe exam. So when we are percussing in the lung fields, all right, if you percuss and you see that, or you percuss and it's very dull, there's dullness to percussion in the intercostal spaces, what does that lead you to think the patient could possibly have? Okay, again, without any imaging or anything like that, what should be in your differential that this patient might have? Presence of pneumonia. Okay, very good. Pneumonia or consolidation. Very good. All right. How do we effectively percuss the lung fields? Okay, what is the best technique? How should we have the patient's arms positioned? When we're percussing, remember, very good. Okay, who's enabled closed captioning? Okay. Okay, all right. What are the signs and symptoms of pneumonia? Dyspnea is one. Coughing, okay. How is the cough? Usually do patients state that, okay, so it's productive, very good. A lot of times patients will have sputum production. It can be rust colored or green. Okay, very good. What other symptom do they have? And how will their lungs sound? Fever, very good. Fever, okay. And sometimes people may not have fever, guys. Crackles, rhonchi, and diminished, absolutely. Chest tightness, they may complain of chest pain. I've taken care of patients who come in and they're pretty asymptomatic sometimes. You know, the only thing that they may have are just diminished breath sounds, or they may have just a cough. And then we kind of work them up and we see that they have pneumonia. And usually it's lobar pneumonia, okay? So very good. Walking pneumonia, I hadn't heard that term in a long time. Okay, so walking pneumonia, excellent. Okay, how do we assess for tactile fremitus? We have the patients do what? Say 99, okay? We systematically palpate the posterior lung fields, right? The posterior chest. And it's going to be with the ulnar aspect of our hand, remember? And we're asking them to recite 99. Very good. Excellent. So again, when we're talking about, for instance, like assessing for pneumonia or infections in our patients, it's very important to understand and question when their symptoms started, okay? So when you're detailing the HPI, when you're getting that information, you need to be sure and go through your old carts, right? So you need to know about the onset of the cough, okay? The characteristics, is it a wet cough? Is it a dry cough? Okay, because that's going to help us to determine what type of disease process it is, right? And most of all, whether or not it's viral versus infectious. Okay, so make note of that. The importance of, especially when assessing for pneumonia or respiratory type disease processes, it's very important to get a good history, especially surrounding the cough. And the reason being is because you need to assess and try to figure out if it's infectious versus viral, okay? And that comes with getting a good history. Let's see. When we talk about edema, so edema of the lower extremities, if someone has mild 2+ pitting edema, okay, when should we expect that their extremities should return to baseline? So after you've palpated and you see that their edema is mild 2+ and it's pitting, how long should it take? How many seconds should it return to baseline? 2 seconds is awfully quick, Guadalupe. Okay, 10 to 15 seconds, guys. 10 to 15 seconds, okay? And y'all commit that to memory. It should return, because sometimes what you've got to remember is that it's caused by all of this pooling of fluid, okay? It's not just going to kind of bounce right back. It's got to take just a few seconds to kind of evenly spread out and be distributed, right? So it's going to take about 10 to 15 seconds is what the normal baseline should be, okay? All right. I wish it were 2 to 3 seconds. That would make me feel better about their disease process. When we talk about pregnancy and the changes that pregnant women experience, especially with the respiratory system, okay? How does the respiratory system work to accommodate our pregnant populations? How is their breathing and their ventilation? What changes do we see? Okay, very good, Andrew. Deep breathing, but it's more deep. It's not more frequent, all right? It's just that we're going to see pregnant women, it's normal to see them taking in deeper breaths, all right? So we don't want our pregnant population to become tachypnic. We don't want the breathing to become faster. And we want to teach them, okay, Guadalupe, it's okay. I kind of figured after I thought about it that might have been what you were thinking. But yes, we want our pregnant populations to breathe in deep. Remember, we even teach them about deep breathing exercises, not only when they're carrying the fetus, but also when they're delivering. So very important that they breathe deeper, not faster, but deeper. Dr. Lewis, you have anything?
No, I'm good.
Okay, are we good in the chat?
Yes.
Okay, thank you.
Let me know if you need me to take over, though. I'll try.
Okay. What do we know about Epstein-Barr virus? Okay, it's also called what? Infectious mono. Okay, very good. Mononucleosis. And tell me what symptoms, especially with palpating, all right? Swollen lymph nodes, and where are they going to be? Anterior cervical and also the posterior cervical. Don't forget that too, okay? So anterior cervical, posterior cervical, they're going to be swollen lymph nodes. And describe the lymph nodes to me. This is very important. Are they going to be soft and mushy? Are they going to be firm and discrete? What's going to be the characteristics of the lymph nodes? Firm. I like that word, Lauren. Firm. Very good. Okay. They're tender. Someone said pain, so they are tender. Okay. So we're going to have firm, discrete, tender lymph nodes of the anterior, okay, and posterior chains. All right. And that's indicative of EBV, or Epstein-Barr virus. What do the lymph nodes of an inflammatory disease process look and feel like? They're tender, okay, so they're painful. What
You
else?
crackled just a little bit, Doctor. Can you repeat the question?
What do the lymph nodes of someone with an inflammatory disease process look like? They're swollen and they're tender, okay? Not necessarily firm. I mean, you're going to be able to tell that they are, that they're lymph nodes, but what's going to be significantly different about the lymph nodes of someone with an inflammatory disease process? They're mobile, soft and mobile, very good, okay? That's key and very important. They are soft and they move, they're mobile, okay? Remember, like with the infectious mono, what we just talked about, those are firm and tender. They're pretty kind of fixed, right? But with inflammation, they're more soft and mobile. They're both are palpable, but you can easily palpate these and they kind of move a little bit more freely. So they're soft, mobile, and tender upon palpation, and that's significant for an inflammatory inflammation or inflammatory disease process. What are the functions of the lymphatic system, guys? What's the functions of the lymphatic system? Immune defense, very good. So fight off infection, clear out debris, filters waste, okay? Clear toxin, very good. So we've got immunological defense, right? And it also helps with fluid balance, all right? So balancing fluid, very good, yeah. Fluid balance, and one other. What about the fat? It absorbs fat, right? So fat absorption, fluid balance, and immunological defense, okay? When do we typically see lymphoid tissue regressing in a child? It normally regresses to adult size by when? What stage in a child? By puberty. Very good. So lymphoid tissue normally regresses to adult size by puberty. Very good. When we palpate or when we're looking at the supraclavicular lymph nodes, okay, so first of all, you need to know where those are. Supraclavicular, okay, when we're palpating in that area, should those lymph nodes be palpable? No, correct, all right, they should not be palpable. So it's a normal finding for them not to be palpable, correct? Correct.
If they are palpable, what should you be concerned with?
Cancer. Yep. All right, we're going to talk a little bit about the cardiovascular system now. So this is Dr. Griffin's MO. This is her jelly, y'all. so you feel free to just chime in whenever, Dr. Griffin. All right, let's talk about myocarditis. What is the criterion standard for diagnosis of myocarditis? First of all, what is myocarditis? Let's talk about that.
Inflammation of the myocardium, the muscle.
Okay. Inflammation of the myocardium. Okay, very good. And that's the heart muscle, right? The muscle around the heart. So
yes.
What? Go ahead, Dr.
It can be prompted frequently by, you can get a viral myocarditis after you've had a viral syndrome, COVID. People came in with viral myocarditis following COVID. You can get it from certain chemotherapy agents and treatments can cause the inflammation of the heart muscle. So these patients often present with pain, the chest pain, and elevated troponins, but they're elevated and kind of flat. So if they come into the ER and their troponins are like through the roof, but you do a second one and it's still through the roof, but it's not really going up, that's on the differential as myocarditis. So the question is, how do we diagnose that? What's the standard procedure for diagnosing that? You can use a cardiac MRI, Amber. That is one of the ways that we diagnose that. That's not the criterion standard, however. Echocardiogram doesn't really show the inflammation in the myocardium, but a good option.
GEE.
So that's the same.
Endocardial biopsy, Amber wins the prize. So
Yeah.
during a left heart cath, we can do endomyocardial biopsy with forceps of the actual cardiac tissue. That's the gold standard currently for diagnosing myocarditis. Very good, y'all.
Yay. That was kind of a tough one, guys, but y'all.
That was
got
tough.
that
It's
down.
not
That was
something
tough.
you see every day. So, I mean, I see it often, but I work at Southwestern where a lot of people come for advanced cardiac care. So, not something that you see every day in Tyler area, that's for sure.
No, I have not seen it at all. Heard about it, read about it, but I've not actually seen it. So, very good. All right, guys, what must be present? What has to be present if you've got someone that comes in with malignant hypertension? Okay, so what is malignant hypertension? Let's cover that first. If you have a patient with malignant hypertension, what does that mean about their high blood pressure? Okay, very good. All right. Both their systolic and their diastolics are usually high. Usually, I think it's like greater than 180 over 120. I need to look that up for sure. Don't quote me on that. Or greater than 200 over 120. I forget now. They're both systolic and diastolic are elevated. Okay. And a lot of times these patients are very refractory to treatment. Okay. So you'll see that they're on multiple antihypertensive medications. What usually do we see present that's diagnostic of malignant hypertension? What symptom? They will have a headache, but that's not exactly what we're looking for. Dr. Griffin's giving y'all a clue. What protein in their urine? They'll have cardiomegaly, but again, so you're looking at these patients and you see this and you're like, you can see this on physical exam, all right? Clue here, you can see this on physical exam in regards to their eyes.
It's called papilledema, bulging eyes.
Very good, Theba. Inflammation or papilledema.
Yeah. So even if you work in cardiac, you have to look in people's eyes. You can see if they have jaundice. It's an important finding in cardiovascular disease. You can see if they have cholesterol deposits in their eyes. You can look for papilledema. So all of these things that we teach you in Head to Toes, they also, you got to remember some of these body systems when you go to a whole different body part that you specialize in.
All right. So let's kind of cover, like, again, our pregnant population. In reference to how their heart is positioned, if you have a lady who comes in, she's pregnant, she's short and kind of stocky, she's short in stature, kind of stocky, where would we expect, in reference to her pregnancy, right? She's pregnant, where would we expect her heart to be located? More to the right or to the left? To the left, very good. And how would it be, more horizontal or more vertical? Horizontal, okay, very good. So more to the left, lying, and more horizontal, okay? Dr. Griffin, do you have anything to add there?
No, I'm sorry. I think there was something we need to go back and revisit on presentations of MIs, but you probably are getting to that.
Yes. Mm-hmm.
I figured you would.
Yeah. And I think so. Let's talk about that. Oh, sorry. Someone said. Oh, we're just talking about, Denny, in reference to our pregnant populations and where their heart is positioned when someone's pregnant. So if you have someone that comes in, they're short and kind of stocky, where would you anticipate, even before, assessing, where would you expect their heart to be located? Okay, because of the pregnancy. So more on the left side and more horizontal. You're welcome. Okay. So you have someone that's coming in and you're doing their past medical history. You're interviewing them and going through their histories. And so she's a 64-year-old lady, and she tells you that she has a past medical history of acute MI, and that just happened last year. Okay. What do we know about patients who present with MI as far as, first of all, let's talk about their presentation. So again, she's already had this, but how do people present when they have an MI? What are some symptoms that we need to be very familiar with for MI presentation? Okay. Chest pain, okay, shortness of breath, diaphoresis, they feel like an elephant sitting on their chest, okay?
And Heidi alluded to very well that women tend to have atypical symptoms. So we need to keep in mind that about a quarter of men and a third of women present with atypical symptoms. So even though they're not complaining of the elephant sitting on my chest and it's radiating down my left arm, we need to keep in the differential that there are other things they can present with: jaw pain, the worst toothache I've had in my life, just some very atypical, sometimes nausea and vomiting and belching. You'd be surprised how many heart attacks I have come in that have been vomiting and been nauseated, and just kind of breaking out diaphoretic. So there's shortness of breath is the angina equivalent. So you just need to keep in mind that about a quarter of men and a third of women will come in with symptoms that are not typical. So just always keep that in your differential.
Very good. All right. When we talk about murmurs, and I know Dr. Griffin can cover this very well, probably with her eyes closed. I like murmurs. I love, guys, for me, like I love when I hear it, I'm like, even though I may not know readily, it takes me a while versus I'm sure she's able to just write it off. Oh, that's a mid-systolic murmur or whatever. But it takes me a little bit to figure out, because again, we're going by our landmarks and I have to think about that. So you have someone that comes in with an audible mid-systolic murmur, okay? And they're an elderly person, all right? So they're elderly, meaning, like 74, 75. They're older than 65, all right? And they have a history of hypertension. So you got to think about all these factors. They're elderly, they've had hypertension for a long time, and now we hear on exam that they have an audible mid-systolic murmur, okay? What do you think is going on with their heart valves? How would you think that their heart valves would be? What would be the condition of their heart valves? Are they going to be very, are they going to be like the heart valves of a 19-year-old? So hardening, very good, stiff, all right.
Fibrotic. So as your pressures are high, you have chronic high blood pressure, just think about those force powers moving past the valve constantly, those shear forces. The valves can get very hardened and fibrosed and remodeled over time. And something also to keep in mind is if in female patients that have breast cancer or male or female patients. I guess I shouldn't just say female, but it's more common in them. If they've had lung cancer or breast cancer and they've had radiation to their chest, and you hear a murmur, you got to think about that radiation exposure, hardening the valves. Aortic stenosis is common in that population. And coronary artery disease also is more common in patients that have radiation exposure to the chest. So that they get coronary artery disease faster than other populations that have not had chest radiation. So just keep that in mind about the sclerosing and fibrosis of heart valves as people age, if they've had high blood pressure, if they've gotten radiation exposure or surgeries to the chest area.
Very good. So what are some normal cardiac changes that occur during pregnancy, guys? Okay. What happens to the ventricles during pregnancy of the pregnant mom?
She's got 25% more blood volume to push out. So what do you think that heart's going to have to do to accommodate that?
Becomes larger, right? So it's going to increase.
Thick muscle. Big, thick muscle during pregnancy.
Yeah. Very good. Similar to heart. And it's got to work harder. So increase thickness and mass, right, of those ventricles. Okay. I can't stress enough, especially with cardiac, and again, I know Dr. Griffin is well aware with this, but the importance of getting a good history, guys. It's very important with cardiovascular disease to obtain a good history, a good family history of our patients, okay? So let's say you have someone that comes in, they're coming in for a routine exam, and it's a male patient, and he's, 50 years old, okay? And both of his parents died from MIs, like in their early 40s, early 50s, right? Okay. His exam's completely normal, or at least what he's telling you is that he's led a very healthy life so far. He has high blood pressure, right? Maybe has some high cholesterol, doesn't have any diabetes. But again, we're going through his family history, and both mom and dad are deceased from acute MIs at young ages, right? It's very important to do a thorough exam on him. It's very important to obtain his family history. And what are some of the things that we're going to be looking for on physical exam? All right. He definitely needs a cardiac workup. We definitely need to know the onset of the cardiac disease in his family. And when we're doing our physical exam on him, what's important? What are some things that we need to be making sure that we assess for and that we document very well?
And I'll give you a hint. There's a couple of things that causes premature sudden cardiac death in patients. So when you hear that in their history, you need to be thinking of a couple of things. You need to be thinking of genetic cardiomyopathies or dilated cardiomyopathies, and you need to be thinking about premature coronary artery disease. It's kind of hard to pick up on premature coronary artery disease on a physical exam, but you can pick up on genetic cardiomyopathies or enlargements of the heart. So you need to be thinking about how do you need to examine someone to assess for a cardiomyopathy.
And so a good clue there was, she said with cardiac, so we're getting warm, dyspnea on exertion. What else would, on physical exam, she said you want to think about enlarged heart. Who said edema?
The PMI. Good job, Amber. The PMI is more to the left, so that's a clue.
Yeah, that's a clue. CHF. Very good,
PMI
Courtney.
Is laterally displaced. Exactly.
So on exam, when you're thinking about CHF, what are we going to be looking for in someone who has CHF, if they have it? Edema to the lower extremities. Very good. Okay. All right. So guys, be sure and examine your patients very well. All right. You want to make sure that they don't have unilateral or bilateral, but mainly bilateral lower extremity edema. You want to make sure that they don't have JVD, that their PMI is not displaced. Okay. You want to question them about, do they have dyspnea on exertion? Do they have chest pain? If they do have, is it just intermittent? Is it all the time? Does it come and go? What's the quality? How long? All of those things are very important to interview the patient about And on exam, you need to be listening very good to their heart sounds, their lung sounds. You need to be checking for fluid, excess of fluid anywhere, and we need to be looking for lower extremity edema, okay? And also pitting edema just anywhere, all right? Their belly, they could have a positive abdominal fluid wave, abdomen, very good, Amanda, okay? So those are all symptoms that we need to be assessing for, all right? So again, you've got to be thinking about that. So you've got someone, you know, that comes in, they have high risk factors for coronary artery disease and cardiovascular disease. So that's all very important. Homan sign, how do we assess for the Homan sign? Okay, we want to dorsiflex the foot. Okay, very good. Dorsiflexion of the foot. All right. How is the knee positioned? Is it flexed or extended? Flexed. Very good. So flex knee and abruptly dorsiflex the foot. All right, and that's going to be if it's positive, then where will they have pain? The calf, okay, very good. The popliteal region, all right, that's very important. It will be in the popliteal region of their calf, okay? So you have a pediatric patient that comes in for their physical exam, their annual exam, okay? And you note, you're listening to them, and because they're having their sports physical as well, you're listening and you're auscultating to their lungs and their heart, and you hear like a sinus arrhythmia. You find a sinus arrhythmia, and their heart rate is faster on inspiration and slower on expiration. What type of, that's common. That's a common finding in pediatrics. It's a normal finding. Y'all beat me to that. Jeez. Dr. Griffin, what are we going to do with these folks? Dr. Lewis?
I know, they're doing so good. Yeah, and EKG, I mean, the pattern is not like dead set regular. You know, they'll have closer QRS waves here and farther apart here, and it's okay. It's not AFib, it's just they have a bit of a sinus arrhythmia when they're younger. Yeah, but all these students are doing so great.
I know. The chat is just blowing up. Let's see. When you're listening to your patient, you auscultate a grade 3 murmur. All right, how about you? How's that going to sound? Is it going to be like soft and dull? Is it going to be loud? What does a grade 3 sound like, guys? Moderately loud.
How many grades are there?
Now here go Dr. Griffin.
How many grades are there?
Here go Dr. Griffin.
Now I'm quizzing y'all. There's 6. That's right. So if you know there's 6, then you know 3's kind of in the middle. So that'll kind of help you out to remember how it sounds. Moderately loud.
Moderately loud. Very good. All right, you've got someone who's an abuser of IV drugs, and they have a sudden onset of fever, symptoms of congestive heart failure. And then they have, when you inspect their skin, they've got these erythematous lesions to their palms. Okay, that's key. Endocarditis, very good, guys. You suspect that those findings are very consistent with endocarditis. Okay, Janeway's lesions. Janeway's lesions. Am I saying that right, Dr. Griffin?
Yes, Janeway. Very good, Phoebe.
Yeah, very good, guys. All right, y'all tell me what you know about Kawasaki's disease. What are the symptoms? Okay, vasculitis, the strawberry tongue, high fever. Very good. Okay, how swelling of the hands and feet. Very good, Andrew. It's very dependent upon time frame. So the onset of symptoms, how long they've had it, and it's like the prodromal of symptoms, okay? So each day they kind of come up with a different symptom, and the symptom that they've had before doesn't really go away. All right. The generalized rash, strawberry tongue. What about their eyes? Their eyes are red, and it looks like that they have what? Their eyes are really red, and it kind of looks like they have, it mimics like conjunctivitis, okay? All right, so what about their lymph nodes and their tonsils? Swollen, okay? And they'll have cervical lymphadenopathy usually. All right. Are these children going to be bubbly and moving all around the room? No, they will come in, they'll be tachycardic, they'll be very lethargic, just not these, they're very sick. And it's very critical to get them to higher level of care. I've actually seen this and diagnosed it in the clinic that I used to work with. And the physician that I worked with was very impressed. This is my claim to fame and being an NP. I recognized the symptoms, had never diagnosed Kawasaki's before in my life, had only taken care of maybe 1 or 2 patients that had it, but I diagnosed it, and we got her to Children's in time enough that she did not have to have IVIG, which is very, very critical. She was discharged, she was worked up, and found to have truly Kawasaki's, and she was discharged on aspirin. And I saw her actually 2 years ago. She's grown up and just done beautifully. And that was, it almost makes me tear up, because just how you think about how critical that is to find and be able to diagnose. And Dr. Johnson was very impressed. Yeah, girl, that is my claim to fame, Crystal. I diagnosed someone with Kawasaki's. But he was telling me, he's like, in all of my, he's had been practicing for 30 plus years. He said, I have only diagnosed, he said, I've seen Kawasaki's twice. I've only diagnosed it once. And guys, he honestly thought when I told him that I knew that that's what it was, he did not belittle me or make fun of me. He just was like, I'm pretty sure that's not what it is. And I'm like, I'm pretty sure that's what it is. Like, it's in my differentials. And so yeah, so it's very important to pay attention. You got to know the signs and symptoms. And when they come in, you've got to know it, diagnose it, and get them to higher level of care, unless you're working at a place like UT Southwestern, and then you just send them to whatever floor they need to go up to. Okay, but that's very important. So just my little
not my floor though, not my floor.
Yeah,
I wouldn't know what to do with them.
Don't send that one to Dr.
Don't do pediatrics. They go across the street to Children's.
All right, guys, when we're examining 2-month-olds, 4-month-old babies, okay, when we're examining their skull, what's a normal finding in reference to their fontanelles? So we've got 2-month-old or 4-month-old, okay? What should we find of soft but not sunken, okay?
Flat.
I'm sorry?
Soft and flat.
Okay, soft and flat. Are they open or closed, the posterior ones? That's kind of what I'm looking for here.
Open.
A 4-month-old. The posterior should be closed, okay? Because if you're examining a 4-month-old and you're assessing their posterior fontanelles, which we're going to be assessing, we should find that their posterior should be closed, because it should close in normal development at 2 months. All right. Okay, so the anterior, still remember the anterior is kind of right here. It's still going to be soft, all right? And it's still going to be kind of mushy. But the posterior fontanelles, they should be closed. If they're not, that's an abnormal finding. Okay, and that's very important. Guys, can y'all take over just for a minute? I've got a phone call here.
I sure can. So when you're assessing a patient, you're looking at the systems, the cardiac and pulmonary work so close in hand that a lot of times those symptoms will overlay. So what would be a sign of something, a patient that comes in with chest pain, what would their respiration rate be that would be concerning for needing further cardiac evaluation? So they come in, they're talking about having chest pain, but what is it about their respirations that would prompt you to do further workup? Tachypnea, very good. So a lot of times when they come in, they're having congestive heart failure. or they're having an acute coronary syndrome, either one, because that's problems with oxygenation. Their respiratory rate is going to be faster because they're trying to get more blood to the system, get more oxygen to the tissues. So very good. So if someone comes in with chest pain and you're looking at their breathing pattern and their tachypnic, you need to look further into a cardiac assessment on that patient. If you're looking at a patient that has edema in the lower extremities, we've already talked about if they have bilateral lower extremity edema, we're concerned with congestive heart failure. There's also venous insufficiency that could be on the differential. But if you have, among many others, but if you have a patient with only one-sided leg edema, what should you be concerned with? DVT, very good, very good. I think that's pretty common, but most people should know, look for a DVT. And things that would prompt you to think about DVT in your history, what would some of those things be? A long car ride, very good. History of smoking, very good if they've been on a long flight. I've actually had diagnosed a patient with a DVT that was a flight nurse, and we had to ground her for a while. So people that are frequently in the air with a change in compression and stuff, I always tell my patients to wear compression stockings and try to take a week's worth of aspirin if it's not contraindicated prior to any long distance traveling. When you're auscultating the carotid pulse and you're feeling for it, what is the main thing that you need to know about it? Do you do them both at the same time, or do you want to do one side at a time? One side at a time. Do we know what heart sound that coincides with? There's 3 heart tones, right? S1, S2, S3, S4. Do we know which one the carotid pulse coincides with? I see it's kind of all over the place. So what's S1? Bump, 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 right? It's the first one. So what's the second heart sound? S2? So the carotid pulse coincides with which heart sound? There's several questions. Does someone know what page that's on?
I'm sorry, what was your question, Dr. Griffin?
Which one the carotid pulse is coinciding with which heart tone?
It should be S1.
Rose and Peterson, page
255.
255. Thank you, Dr. Lewis. When someone complains of claudication, what disease process should you think of? What is claudication? Peripheral arterial disease, very good. So it's pain while you're walking. So people don't have usually pain at rest because there's no demand on the system, right? So the arterial flow can get through a little trickle and get down to the muscles as long as you're sitting doing nothing. But when you get up and start walking around and you put a demand on the muscle tissues that they need more oxygen, you can't get enough blood flow through the arterial system. That's a sign of peripheral arterial disease. A lot of times they'll also complain of nocturnal cramping when they're laying this way. They're not getting enough blood flow when they're lying horizontal. So patients will come in, complain of pain with walking, relieve with rest, and then nocturnal leg cramps as well because they're not getting enough flow down the leg, and they'll wake up with leg cramps in the middle of the night. So very good. And that is indicative of a pain from muscle ischemia. It's basically what you need to know. The muscle's hurting because it's not getting enough blood flow to it. Are you back on, Kristen? Are you good? I think we're back to some more baby stuff.
Okay.
So, you know, that's not my bag.
Okay. All right. Let's see, guys, when we have patients who are on antibiotic therapy, all right, especially if it's extended, And we sometimes will see the hairy tongue. Crystal, y'all just slow down now. Goodness. Dr. Lewis, did you meet with these students before we met?
I know someone's been telling them something. They on it.
They on it.
Y'all are on it. Y'all know that about antibiotic use, okay? The hairy tongue, all right? Y'all be sure and note that, okay? All right, you got a kid coming in with fever, ear pain, and a headache. You notice that their right tympanic membrane is erythematous, okay? The condylitis is displaced. What's their diagnosis? Acute otitis media. All right, very good. Acute otitis media. Very good.
What do we think of a child that comes in with a heart rate of 100? What do we think about that? The heart rate being 100, the resting heart rate in a child.
It's normal. Very good. So 2, 3-year-old, 4-year-old.
Very good. Normal. Very good. It's normal. Mm-hmm. Very good.
Let's see here. What do you know about peritonsillar abscess? Tell me the symptoms of peritonsillar abscess. How might a child come in and what might the parents tell us that they have, the child's symptoms are? Difficulty swallowing, that's key, okay? Pus and discharge, where's the pus and discharge gonna be from? The tonsils, okay? Bad breath, so their breath may smell really bad. What is a sign that we need some immediate attention or action? If they say that their child's what, or we see on exam that they're drooling, okay? What does that indicate? That there's compromise of what? The airway, okay? So they're having difficulty breathing, they have airway compromise, okay? So high fevers, sore throat, ear pain, that can be symptoms that the parents say, hey, you know, they've had high fever, 102.3, 103.4 over the past day, you know, within the past 24 hours. Sore throat, their ears may be hurting, okay? And then you note that they are having difficulty swallowing. You see that they're drooling. You need to definitely be thinking about peritonsillar abscess, all right? How does pleural pain differ from chest discomfort? What is the key thing when someone comes in and we're able to, because they're not going to say that they're having pleuritic chest pain there unless they are a healthcare professional, okay? So how do we know when someone comes in, very good, Guadalupe, it happens when breathing in, okay? It's precipitated by breathing, all right? So know the difference from pleural pain and just chest discomfort, okay? Dr. Lewis, do you have anything else? Do we think we covered everything?
I think you got everything.
Dr. Griffin?
I'm double checking.
And great job as always.
All right.
I know. How you fit this all in one night, I don't know. I'm double checking all my notes online just to make sure.
Guys, if I didn't mention anything, then I would not focus on that. These think tanks are designed because we've gone through and we've looked at what we feel like you need to know for your exam, okay? All right?
Oh, I know one thing we didn't go over. I found one thing we didn't go over.
You would find something.
What?
Yeah, I'm thinking I'm doing good.
This is the highest risk factor for oral cancer in the history. What's the #1 risk factor for cancer? I don't remember us going over that.
Yeah, we didn't. Thank you. Smoking, tobacco use, very good. Who said HPV? We said oral cancer.
Oral.
Let me look in this chat. Whoever that is, you better not miss that.
Danielle,
you better not miss that. Danielle. She said, my bad.
Yes, if you have a list of different patients and which one would you feel like was most at risk for oral cancer, it will be the smoker.
The smoker, very good.
Is one of the highest risks for most things, smoking and diabetes, the double whammy. Mm-hmm. But tobacco use is the high risk for oral cancers.
Thank you, Dr. Griffin. As always, we enjoy doing the think tanks. I love to see how much y'all are participating. I appreciate that very, very much. Y'all focus on what we've gone over tonight and don't worry about the rest of it. Everything that's on the blueprint is definitely what you need to know, and you do need to know it for practice, all right? But you kind of focus on the things that we've gone over, and you should do well on your exams, okay? I appreciate you all coming to the think tanks and your participation. Again, just remember to please bear with us and be patient as you all have done. You all have been very, very kind and in being patient with us with all the technical challenges of this semester. This was definitely new to all of us, including Dr. Reiser. And I can't apologize enough for all of that. I'm so sorry that you all are kind of having to deal with that. But again, such is life, right? We're learning to adapt to change. And sometimes it just doesn't always go as we would plan. And just as frustrating as it is for you all as students, is twice as frustrating for us, because you can imagine we tell you one thing and then we find out from our higher ups and IT people that it's a different way. So then we've got to come back, we've got to make changes, and then we have to tell you all, okay, we're so sorry, but this is now changed. So it doesn't always go as planned, and that's why we have to continue to be patient with ourselves and just roll with it. Like Crystal said, you just got to roll with it. That's nursing, and that's why that's why we are in the profession that we're in. All right.
That's right.
Yes, but God, like Dr. Griffin's shirt, but God. Yes.
I just came back from a mission trip to Brazil, and our word of the week was flexible. Be flexible. You never know what's going to show up when you come into a village, in a foreign country, or you have a layover in Miami or Panama City, and you're just sitting in the airport. So you just never know, but we're going to be flexible and press onward to win the prize, because that's what we're all here for, is to get through this course. Because in our heart of hearts, we all want to take care of other people, and y'all are doing an excellent job. I've gotten through some videos. I'm very impressed with all y'all's videos. Y'all are doing great, especially for it just being the midterm. I've had some near perfect videos. So I'm just very impressed with y'all's performance, how much you're putting into the course. And believe me, we still learn something new every day. Dr. Garrett and I talk often on the phone almost every day, and we're talking about something new that we've seen in the hospital that week. So we never stop learning. We're always learners, and I think y'all are just really doing a great job being flexible and adapting to this course, and all the hard work that you put in will pay off in dividends in the long runs, because you will literally save somebody's life. You will literally save more than one person's life. And that's very rewarding. Or you'll be with someone at the end of their life, which also in my job is one of my most favorite things, is the palliative care aspect of end-stage heart failure, end-stage heart disease. And so we're blessed to have the privilege that God gave us the wisdom to be able to get through these courses and to learn these things. Not everyone can be a good student. So I really appreciate y'all utilizing your strengths and pressing onward through all of the changes day in and day out. I know there's some questions about the in-place, signing up for the in-place to document your clinicals. We're working with Dr. Reiser on that, and we'll get back to you this week on information on that if some of y'all are having difficult getting logged on. So we'll get it sorted out. So thank y'all. Keep pressing on.
So someone said about, do you have to make an 80 to pass the course on the midterm? So I would say just to make sure that you do make an 80, okay? The main thing that you have to make an 80 on are your exams, all right? You have to make an 80 on the exams in order to, your average has to be an 80. Let me take that back. You have to have an average of an 80 or above to pass this course. So you could make 100 on your midterm video and score perfectly in your final, but if you don't have an 80 plus exam average in this course, and in all of your courses for this F&P program, you will fail the courses, okay? So that's kind of what you need to bear in mind. That's why it's very important. I cannot stress enough, and I think you all see by now, it's important to come to these think tanks.
Yes.
Like we said, we don't have to do this. This is something that we are doing in order to continue to ensure your success. but by right, we've done that by providing the materials in the course, okay? It's up to you to study, to review, to ask questions, and this is not something that we have to do, and I don't mean to keep reiterating that, but it's important. It shows us not only that you are interested, you're taking ownership of your learning, but you're also being respectful of the fact that, hey, our professors are taking out extra time to do this for us, and it's important that you show up, okay? So if you want to be successful, thank you, Dr. Lewis, for answering that, then you will do what it takes to get through the course, all right? This is, and I want to say this, I feel like that I'm putting this out here because I feel like I need to say it, so I'm just going to say it. Guys, we do offer a lot of leniency, okay? Moving forward, some of your courses may not be as lenient. We also, with that, try to teach you the importance of being responsible in order to get you ready for some of these courses that may not be as lenient, okay? It's not a spoon feeding. It's truly, some of you, this is the first class and course that you're taking in this program, all right? And so it's basically designed to try to teach you guys about time management, what's important. And that's why that's part of the think tank, is to teach you kind of what you need to focus on, all right? Because the blueprints can be somewhat overwhelming. There's a lot of information on there, and it's all good. It's all good, and it's all need to know for practice. So just bear that in mind. You know, we're very lenient a lot of times with the due dates. Number one, we understand that there have been lots of things that have happened that are outside of y'all's control, okay? And I do not feel that it's fair to you as students, if that's something that you cannot control, to not give a little bit of fairness and leniency there. I will preface this with this. All of us are working, okay? So the excuse that you're working, that's not an excuse. I'm working too. I'm working every single night. All right. Some of us are working. We're working 2 jobs.
Two jobs.
Employment is not an excuse, because you have to provide for yourself and you have to provide for your family. What comes in is the fact of your time management skills, and that's what we're here to try to help you to kind of garnish. So we are lenient with certain things, but you know, we're not gonna be abused. And if there's something going on, you guys need to let us know early on. I don't need to know. Don't come sending us an email the night that your assignment is due, talking about that you've been in the hospital, you've been sick, you've been this, and you've been that, okay? It is important to communicate. Communication is key. It's important all throughout life. And I'm not fussing. I'm telling you all so that going forward, these are good ground rules for life, okay? You need to communicate what's going on. If you call me, you text me talking about, it's one thing if you've had a car wreck or you just this, that, and the other, but if you have known that this assignment is due and you're texting at 15 minutes before it's due that you've had this and you've had that, you could have told me that 24 hours before, and it makes it a little bit easier for us to try to figure out how to help you. I feel like all 3 of us are very approachable. We are very considerate. We've been very lenient, and we will continue to be as long as we don't feel like we're being abused. Okay? So if there's anything that you need, again, we're here. Y'all email us with your questions, and if we can't answer it, we'll get to you within 24 to 48 hours with an answer. All right? Does everyone understand that? That's just some adulting lifing rules. Okay, going forward. Dr. Lewis, do you have anything?
No, ma'am.
Okay. Dr. Griffin?
I think you said it all, Dr. Garrett.
All right, folks.
We love all y'all. We love
We
teaching.
do.
We're enjoying this class. We can't
Y'all
wait.
excite me with these think
y'all
tanks.
doing.
I get so excited now. I'm just like, y'all are so interactive, and that's what we like to see, and I appreciate that. And for the most part, this time y'all were ahead of me. I couldn't even get the synopsis and the question out. So
I could not even keep up.
No. I hope y'all have a good night. Happy studying. If you have any questions about anything, again, don't worry about your midterm and your SOAP notes. Y'all just keep moving forward, okay? We're going to get those graded and turned around just as soon as we can. Y'all just keep working in the course, and if you need anything, reach out to us, okay? All right, virtual hugs. We'll see y'all next time. Bye-bye.